Good afternoon, everyone, and welcome to the HSE Winter Preparedness for Health and Care Settings webinar. I'm Dr. Augustine Pereira, Director of Public Health and Winter Resilience Lead in the National Office for Health Protection, and it's my pleasure to welcome all of you here today. The webinar is being recorded, and we expect to address all of your queries during the presentation. So please, could you use the question and answer function on Teams to post your questions during the webinar? It may be prudent to wait to the completion of that session for then posting the question about the session, because often the queries you have will be addressed. Could I request everyone to stay on mute because I'm getting an echo, and it'll be helpful, especially given the number of people present. If everyone can stay on mute, that would be excellent as well. So as I mentioned, the webinar is being recorded, and the recording will be posted on the website. That's on the page as well, the Winter Preparedness web page on the HPSC website. So we have a range of presenters today, which represents the partnership approach we've taken at national level, bringing together partners from across various functions nationally, but also regional colleagues to ensure that we are best prepared for this winter. So the format for today, we'll have the introduction in a moment from Dr. Eamon Moore, who will give us a keynote address. We'll then move on to a theme of planning and preparing, where we'll talk about the importance of vaccination, the Winter Ready Guide that was developed last year through the Winter Planning and Response Forum, some fundamental principles of infection prevention and control, which forms part of the planning and preparation, but also a vital part of response as well. We'll then move on to case identification and management, where we'll talk about recognizing and treating acute respiratory infections, and move on to clinical management of outbreaks. We'll end with a quick look at some of the resources that are available to all health and care systems. And finally, we'll have a Q&A session with the expert panel before we close. So before I hand over to Dr. Omore, I want to just bring to your attention these two resources that are very helpful to understand the levels of circulating disease. Often it is this that gives us a trigger, an anchor for us to start or enhance our response. The Respiratory Virus Notification Data Hub was developed by HPSC and launched last year, which gives us rich insights into all the respiratory viruses, COVID, influenza, and RSV. In addition, the HPSC also publishes an integrated respiratory virus bulletin. It's published on Thursday every week, and it includes the latest surveillance data on respiratory viruses. And it's got a range of information, including information on severity and impact, information on outbreaks, the virology and genomic surveillance, wastewater surveillance, international updates, as well as links to other national respiratory virus reports. So it's a very rich source of information that's available and published weekly. So I now have the pleasure of introducing my boss, Dr. Eamon Moore, who's the Director of National Health Protection. He will give us a keynote address and bring together some of the reasons why we as a system come together every winter to prepare the health and care system for the winter ahead. So over to you, Eamon.
Thank you very much, Augustine, and good afternoon, everyone. I'm Eamon O'Moore. I work as Director of the National Health Protection Office. Firstly, I just want to thank everyone for your time and interest today, and also to everyone who's helped to prepare this webinar. Winter is a predictable event. However, every winter brings challenges. Some of them we can anticipate, some of them come upon us. But it's fair to say that it's an incredibly challenging time for our health system, and very importantly for the people who work within it. In this webinar, we're going to hear a lot about the sort of work that we've been doing collectively to prepare better for any of the challenges that winter brings. I certainly want to emphasize the importance that we as healthcare professionals have in protecting the people we look after and protecting our own health and well-being, as well as the health services we deliver, through taking up appropriate offers of winter vaccines. And this is something we can all do to protect ourselves and our services. We also are aware that vaccines alone will not mitigate all of the potential impacts of winter challenges. And so we'll be hearing a lot about the approach to infection prevention and control and the importance of this as a central plank of our defenses against impact of winter pressures. We're also going to hear about the responses that we have in terms of outbreak and incident control, recognizing that even despite all the best efforts, nosocomial outbreaks and care home outbreaks can and do occur. We've enjoyed some real success in recent winters in recognizing, responding, and containing outbreaks of both flu and respiratory infections and COVID. And this is a testimony to the preparatory work, the training, the development that is done, and also the development of evidence-based guidance, which are there to ensure that our teams know how best to manage and respond. But even with all the guidance in the world available at our fingertips, there is still a high degree of clinical judgment, of public health insight, and of collaborative work required to ensure that we are already prepared for this. So I encourage you all to pay close heed and good attention to the experts and colleagues that we have on the line today, who will direct you to advice and information resources that you will rely on during the course of the next few months to get us all through this together. It's also important that we support each other. We in National Health Protection work very closely with a number of teams across HSE, with our regional teams, with a range of partners outside and HSE and in academia in order to understand and address the problems we face. We're using increasingly sophisticated capability around disease modeling to predict when we might see pressures upon us. And we've been delivering innovative practice, including in immunization. And many of you will have been involved in the RSV immunization program, which has been delivered last year.
Here we are. You can hear them now. Great. Okay.
Last year to great success, and also this year we're developing a new program. Just to be mindful, there are noises off, people, so we could just look to mute microphones and make sure that we're not cross talking. But there you go. That's an example of real life intervention and risk mitigation from the National Health Protection Office. I want to end by saying in my introduction that we know that every winter brings challenges, but we are committed to learning from the experiences of every winter. So as we address the challenges together, we also take the opportunity to learn how to do it better next time. The work that you're going to hear presented today, the guidance and evidence presented, is informed by our collective experiences as a health system. Your insights, your contribution, your work has contributed to making what we do even better. We're committed to learning from practice as well as applying the evidence base. We're committed to building the evidence base. We want to work together with our colleagues in order to understand how to do this better every winter. And we recognize the importance of protecting our health services during critical times, not only to protect people and services from the impact of winter directly, but also the indirect effect that can come from services having to be deferred or delayed due to an impact on bed availability and access to primary and secondary care services. So the impact of preparing better for winter not only has direct benefits, but also protects wider services that we want to see delivered to the population we serve. So as we start to move into winter response mode, and as we start to think about the months ahead, we do so confident that we've prepared well, that we have been doing a good job in preparation, and now we're on the point of delivering that work. We will do it together, we will do it with support from each other, and we will also do it in a way that allows us to learn as we deliver. So I'll hand back to Augustine. Thank you for your time and effort, and I look forward to what comes out of today's conversation. Thank you.
Thank you very much, Eamon, and thanks for that call to action. So without further ado, let me introduce Louise Maron, our first speaker. She's a consultant in public health medicine. Dr. Maron has been leading on winter vaccinations for National Immunization Office and the HSE, and has in-depth knowledge of how vaccines work and why it's important for us to get vaccinated this winter. So let us hear from Dr. Maron, please.
Hi, Augustine. Thank you very much. And good afternoon, everybody. It's lovely to see so many people on the call. So go on to the next slide there, Mary. Thanks a million. So I just wanted to start really by giving a little overview of the programme for both influenza and COVID-19 this year. And then in the rest of my talk, I'm really just going to focus on us as healthcare workers and talk about why it's important that we get vaccinated, maybe address a few common queries that I've heard over the last couple of weeks and months, and then talk about how we might make some efforts to improve on healthcare worker vaccine uptake. So the programme began on the 2nd of October, so nearly 3 weeks ago now. And just to say, in terms of giving an overview of how the programme will be delivered, so for people in whom vaccines are recommended, the vaccines are available for free by GPs, pharmacists, HSE vaccination teams, and peer vaccinators then for healthcare workers. And then HSE vaccination teams provide vaccine clinics on site, including in residential care facilities. And I know we have a lot of people here today who work in residential care facility settings. And then I really just want to highlight at the beginning that all healthcare workers should have access to vaccines in their workplace. So that could be through vaccine clinics, and there's lots of details available online, and links will be circulated with the resources from this webinar today. And then also, of course, it's important to remember that all healthcare workers can also attend their GP or pharmacy. And I know that's how I got my vaccines this winter, very convenient to be able to do it maybe over a lunch break or on the weekend. So they are available for us as healthcare workers for free in the community as well. So on to the next slide there, please, Mary. So this is just some of our materials. And again, I'll be sending around some links at the end that link to the huge amount of resources we have for both flu and COVID on the NIO website, with a lot of specific resources for healthcare professionals. Go on ahead there, please. Yeah. So just to talk about who is recommended to get a flu vaccine this winter. So anyone aged 60 years and older, anyone who's aged 18 and older who lives in a long-term residential care facility, all healthcare workers, all pregnant women at any stage of pregnancy, anyone who's 6 months and older who's at increased risk of complications. And I'm not going to go through all the complications there, but you can see it's a very broad range of people with underlying medical conditions, all children and young people aged 2 to 17 years, and then carers and household contacts of those who are at risk of influenza-related complications. And then lastly, but importantly, people who have close regular contact with pigs, poultry or waterfowl. So I suppose for this audience, the most important thing to remember there is we see all healthcare workers recommended to get a flu vaccine this winter. On to the next slide there, please, Mary. So I just want to talk a little bit about why. So why are we asked to get vaccinated? And I've included in this reasons why other groups as well are recommended to get vaccinated, because we as healthcare workers have a very strong role in advocacy, and really a recommendation from a healthcare professional is one of the most powerful things in predicting why people get vaccinated. So I just wanted to take some time to talk about why. So influenza is highly infectious, and it's really important to be aware that the illness is more severe in older people, people who have weak immune systems, and people who have any underlying medical conditions like heart disease, lung disease. It's also more severe in children who are aged 4 years or under, and it's more severe in pregnancy. And I just think it's really important to be aware that the majority of deaths, up to 90% of deaths from influenza, occur in older people. And what happens is, after getting the flu, many people will get a secondary bacterial pneumonia, or they may have exacerbations of underlying diseases like COPD or cardiac disease. And really the key message, and what we say all the time, and it is true, is that the influenza vaccine is the best available protection against infection and those serious complications. Sometimes people ask questions about the effectiveness of the flu vaccine. So is the vaccine effective? And the truth of that answer, and the correct answer, is that the effectiveness of the vaccine can vary. And it can vary depending on the strains of flu that circulate. And it can be different in different population groups. So the vaccine is more effective in younger people sometimes than in older people. And it's true to say that for a given season, that the actual figure, the actual vaccine effectiveness will not be known until the season is over. But it is also true to say that if people who are vaccinated get infection, that their risk of serious illness and death from influenza is significantly reduced because they have been vaccinated. And I think that's a really important message. So it really does provide that best available protection against infection and complications. Then sometimes people also ask why. Why do people need to get vaccinated every year? And the reason for that is that vaccination is recommended every year because our immunity declines during the year after vaccination, and also because the circulating strains of influenza virus change. They change from year to year. And every year, the vaccine is updated with the strains that are expected to circulate, and that is based on advice from the World Health Organization. On to the next slide, please, Mary. So as a healthcare worker, why? Why do I need the flu vaccine? So as healthcare workers, we're 10 times more likely to get the flu compared to the general public by the nature of the work that we do and the fact that we're meeting people with flu. And as healthcare workers, we can get very unwell with flu. And even if we have no underlying medical conditions, we can still get seriously unwell and get complications. And additionally, our risk of spreading flu to others, including to our own family members and within our communities, is much higher than it is for people who are not healthcare workers. So we can play our part as healthcare workers in protecting ourselves and in preventing the spread of flu by getting vaccinated. And additionally, as we all know, people who have weak immune systems and people who are older, they may not get as much protection from the flu vaccine themselves. So therefore, they rely on us as healthcare workers to keep them safe and to protect them by getting vaccinated. And then we know that in healthcare settings where there's higher rates of flu vaccination, there are lower rates of flu. There's less outbreaks and there's less deaths in people who are 65 and older, particularly who, as I said, are those at highest risk of experiencing really difficult illnesses. So I've just included for information a link on the slide there, a specific resource we have for healthcare workers that goes through some more questions. But on to the next slide there, and I'll go through some more now here today. Thanks, Mary. The next slide. So how long does it take the vaccine to work? So the flu vaccine starts to work within 2 weeks, and that's why we say that ideally it should be given early in the influenza season. And linked to that, I suppose, is the question, can I get flu from the flu vaccine? And the answer is no, you cannot get flu from the flu vaccine. It is not a live vaccine, but it does take 2 weeks to develop immunity after infection. So the vaccine needs time, and it is possible to get the flu if you're exposed to the virus during this time. So that's really why we say get it as early as you can to protect yourself before flu begins to spread. So if you're here today and you've had your flu vaccine, then excellent. And if you are thinking about it, I hope this information is useful, and the best time to get it is now. And then, is the flu vaccine safe? So yes, the flu vaccine has been proven to be a safe vaccine, and severe side effects of the flu vaccine are extremely rare. And I would like people to be reassured that the safety of the flu vaccine is closely monitored. And flu vaccines have been given for more than 60 years. It's actually closer to 70 years to millions of people worldwide. But it's absolutely okay to have questions about vaccines. I have questions myself all of the time, and there's lots of information available. And I would just encourage people to get their information from trusted and reliable sources. So as I say, we have a slide of resources to direct you to information that we have, but further information about flu vaccine safety is also available in the what's called the SMPC, so the summary of the product itself on medicines.ie, and I have a link there on the slide to that for anyone who may wish to know more. On to the next slide there, please. So what are the common side effects of the vaccine? So many of us will know from previous years, you can sometimes get a sore arm at the site where you've had the injection and some aches and pains and a bit tired. They're very common side effects, but they certainly pale in comparison to what the symptoms of influenza infection are. I did want to include this because it's very important, I think, in a predominantly female healthcare worker workforce to address this question. I'm a pregnant healthcare worker. Should I get vaccinated? And the answer is yes. As I mentioned, a seasonal flu vaccine is recommended in pregnancy, and it can be given at any stage in pregnancy. And it works by providing protection and also gives protection to the newborn baby during their first months of life. And flu vaccines have been given to pregnant women for over 50 years. And we have a separate leaflet specifically around flu in pregnancy with additional information. And I have a link to that on the slide there as well. So next slide, please, Mary. So just a question we've gotten recently, and it may be from people that are quite familiar with materials over previous years, why is the vaccine called IIV this year instead of QIV? So last year, all of our materials referred to QIV for the injectable flu vaccine for adults. And that's because last year's vaccine was a quadrivalent influenza vaccine, QIV. But this year it's changed, and all vaccine formulations this year are trivalent, and they're called inactivated influenza vaccines, IIV. What that means is that they contain 2 type A and 1 type B influenza virus strains, and that's what's recommended by the World Health Organization for use this year. So I suppose it's important to be reassured that the vaccine is kept under review and the components of the vaccine are kept under review, and things when they're not needed anymore are not included in the vaccine. So that's the reason for the change, and that's why it's called IIV instead of QIV this year. And then, is there anyone who can't get the flu vaccine or who shouldn't get the flu vaccine? So most people can get it and can safely get the flu vaccine, but it isn't recommended if you've had a severe allergic reaction to a previous flu vaccine, so that would be an anaphylaxis, or if you have very low levels of white blood cells, and you'd obviously be linked with medical team if that was the case. So you would know that. And then there's a few other conditions whereby you may need to speak to a specialist doctor. So that would be if you're on very complex chemotherapeutic drugs, or if you've had a previous egg allergy where you've ended up in ICU. So there are just a few reasons why you might have to think about speaking with a healthcare professional for advice around getting the flu vaccine. But really the message is most people can get the vaccine very safely. Next slide there, please. So this is just another few pictures there of the materials for our COVID programme. So I'll just very quickly go through COVID this year and some of the changes. So on to the next slide there, Mary, please. Next slide, please, Mary. Thanks a million. So I'll just be talking through the recommended groups when Mary moves the slide on there for COVID vaccines this year. And this year, anyone who's aged 60 years and older, anyone who's aged 18 years and older, or anyone over 6 months with an underlying medical condition or immunocompromised is recommended to get a flu vaccine. Recommendations for healthcare workers have changed this year. And if you're a healthcare worker and you're in one of those groups, it's recommended that you get vaccinated. But if you're a healthcare worker and you wish to get a COVID vaccine this year, you can. And it's recommended to wait 3 months from either your last infection or vaccine. Just wonder if we could move ahead there, Mary, for the audience, maybe to the next 2 slides, please. And on to the next one, yeah. So same thing, why do we ask people to get vaccinated against COVID-19? And I think the important message here is that what's been true from the beginning of the pandemic, which is that if you're older or you have an underlying medical condition, you are at increased risk of severe disease. And the COVID-19 vaccines are really effective at protecting against hospitalization, severe disease and death. But unfortunately, and many of us may have personal experience of this, the protection that the COVID-19 vaccines give us against getting the infection is quite limited, and the protection can wane over time. And in order for our protection to be increased, we need a boost, and that can be boosted either by infection or vaccination. So on to the next slide there, please, Mary. So what are the key messages for healthcare workers about the COVID-19 vaccine this year? So while the vaccine recommendations have changed, vaccine remains the best protection we have against the serious complications of COVID, and all healthcare workers who are in a risk group should get vaccinated. And then healthcare workers who are younger, while we may be at low risk of severe COVID-19, we do have a high exposure risk to COVID, and any healthcare worker who wishes to get a COVID-19 vaccine can do so. And the vaccine recommendations are constantly kept under review by NIAC, and like the flu vaccine, COVID-19 may be available in workplaces and is also available for free in the community. So on to the next slide there, please. So I mentioned that we wait 3 months, and if in terms of getting both flu and COVID-19 vaccines at the same time, if you're recommended to get both vaccines, you can get them at the same time. There's no concerns with safety, but you don't have to. You can get them at different times if you wish. They can be given at any interval. On to the next slide there, please. And we'll go to the next slide again. I just want to really quickly, before I finish, talk through this really, and I just want to acknowledge in this first diagram that it's quite complex, the decision making in and around why healthcare workers choose to get vaccinated. And our decisions to get vaccinated can be influenced by a lot of different things: how we think and feel about whether we're at risk of infection, leadership, and how supported we feel by leaders in our workplaces, and then practical things like how easy is it to get the vaccine. So on to the next slide there, please. So looking at the literature, really the key areas that are important to focus on to improve vaccine uptake are taking away any barriers to vaccines, strengthening leadership, focusing on strategies that build trust, ensuring that there's clear messaging for healthcare workers, and then offering personalised reminders. And then on to the next slide for my last question really today, which is, I'm a manager, how can I increase uptake in healthcare workers? And I realise that, a lot of people are doing this, and I want to acknowledge all of the efforts of everybody who's involved in leading vaccination programmes. But I suppose just to be aware that these are the evidence-based approaches. So removing any and all barriers, trying to facilitate flexible on-site access for healthcare workers, giving multiple opportunities to staff to get vaccinated, things like going around the wards, being outside grand rounds, making sure there's clear communication for healthcare workers and visible promotion with lanyards and booklets, reminders for people through text messages, and a lot of that is being done nationally through emails, etc. as well. Having strong leadership and supporting your staff to get vaccinated, giving people time to get vaccinating, and supporting peer vaccinators to be able to do the training that's needed. and then visibly promoting and encouraging vaccination in your organisation. These are things which sound quite simple, but actually there's a lot of evidence for them, and particularly when interventions are combined across all of those different components, it's really effective at improving vaccine uptake. And the next slide then, please. So key messages, get vaccinated. The flu vaccine is strongly recommended for all healthcare workers. It's the best protection we have. And for COVID-19, any healthcare worker who wants to receive a COVID-19 vaccine this winter can do so. And if you are in a recommended group, you are recommended to get the vaccine and you are at high risk of being exposed to infection. And the vaccines are available free of charge for all healthcare workers through staff vaccination clinics and in GPs and pharmacies. So on to the next slide there, Marion. It's really just to thank you all, everybody who's on this call, who's involved in vaccination programmes, any healthcare worker who's gotten vaccinated. On behalf of the NIO, thank you for protecting our population from vaccine preventable diseases. I am going to put in the chat in a minute our clinical queries email address in the National Immunisation Office. I unfortunately won't be at the Q&A today, but if there are any specific clinical queries for the NIO, we're always delighted to take queries from healthcare professionals. And thank you all very much for your time and attention today. Back to you, Augustine.
Thank you very much, Louise. And we are aware of some technical issues. There are several people that I understand who are trying to get onto the webinar. We can see about 112 people on this call, but there are more people on chat who cannot hear or see anything. So we're trying to figure out what's happening there. So please bear with us. Just wanted to mention that to any of you who are also getting messages from your colleagues who are trying to join the call. By the way, this webinar is being recorded, so those of you who are on the call, you can hear us here and can also put questions on the Q&A function that we can respond to it towards the end. So thank you so much, Louise, for that presentation about the importance of getting vaccinated. I mean, I learned something new. I hadn't realized that we've been immunizing and providing vaccinations for flu for 60 years. That's really interesting, isn't it? And so much safety data on the safety and effectiveness data on the vaccines as well. So let's move on to our next presenter, who's Fionnuala Dore. She's the Director of Nursing in the Community Support Team in HSE Dublin South and Wicklow. During COVID times, we will all remember the COVID response teams, and there were several iterations of it. It became now, most recently, the community support teams, initially aligned to CHOs or community healthcare organizations, and now it's moved to the new regions. And Fionnuala works in a specific IHA region, which IHA within the region, HSE Dublin South and Wicklow IHA. Fionnuala is also a member of the Winter Planning and Response Forum that planned this webinar, but also produced many of the resources that are available today as well. Over to you, Fionnuala. Thank you.
Sorry. Good afternoon, everybody, and thank you for joining. So as you're aware at this stage, Regulation 27 of the Health Act 2007 for the care and welfare of residents in designated centres for older people requires that the registered provider shall ensure the procedures consistent with the standards for the prevention and control of healthcare associated infections published by HIQA are implemented by staff. HIQA National Standards for IPC in Community Settings 2018 Standard 3.4 says that RCFs must ensure outbreaks of infection are identified, managed, controlled, and documented in a timely and effective manner. Now, as you can see, these documents here you will all be very familiar with, but the main theme of each of them is that planning is an essential component of your preparedness for the winter season, but also for outbreak management. Next slide, please. So, as I said, our main thing is planning. We want to plan for the winter season ahead. So you need to check your facility's winter virus preparedness plan. Make sure that it's up to date and based on the AMRIC guidance for RCFs. The plan should include staff resilience, vaccination, an isolation plan and a communication plan. This should be updated at a minimum of once a year, but ideally after each outbreak, so that learning and planned improvements can be documented. You need to ensure all staff have access to and read the preparedness plan and your infection control procedures. Offer all residents and staff the recommended COVID-19 and flu vaccines. Hand hygiene is one of the most effective measures in preventing the spread of infections, so ensure that liquid soap and disposable paper towels are available and adequate supplies are stocked. If safe to do so, place alcohol gel in places where hand washing facilities are not available. And ensure appropriate waste management, including increased clinical waste capacity and collection during an outbreak. For your staff, ensure symptom vigilance. Staff are aware of who they report symptoms to and not to report to work if unwell. Your staff replacement. If your staff level is depleted, who do you get additional staff from? Is there a staff pool? Are the contact details for that staff pool up to date? Or are you getting your additional staff from agencies? Staff on designated floor or areas are recommended not to cross over during outbreaks, and this is a very important component. Designated break facilities. Can you facilitate areas where your staff can be separated, especially for those that are working on wards or units that have an outbreak? Can they be separated from other staff within the facility? And changing in restrooms. How are they managed? How are your cleaning protocols? How are staff uniforms managed? How are they going to be taken home? Are they cleaned on site, or are they going home with your nurses or healthcare assistants? If they are going home, how do you protect the families that are at home also? So these are all got to be considered when you're planning for your winter season. Next slide, please. So you will all at this stage have received your respiratory viral infection resource pack, and it comes from HPSC, and there is there under your seasonal influenza guidance. So in this comes your algorithm for testing for ARI and RCFs, the IPC and public health guidance for outbreak, your guidance on testing for ARI and RCFs, your quick reference poster, which is guidance for respiratory outbreaks, and your winter preparedness and outbreak management checklist, HPSC. I have included there a little picture of the HSE Dublin South East version of this. It's a very comprehensive document, and it's very useful to all the healthcare facilities to actually go through it to make sure they have everything in place. You now at this stage have many IPC champions and link practitioners in your staff. So if not, you need a named staff member. This named staff member needs protected time to complete hand hygiene training and audits, and donning and doffing spot checks. Certification and staff training database and signage prep in advance, donning and doffing and PCRA. The important things for this is that it's done in advance. It's not something that needs to be done as soon as an outbreak happens, but should be an ongoing process that it is in preparedness for an outbreak. Your vaccinations, promotion of vaccinations among staff, signage in your staff changing rooms, and signposting towards the HSE land module for flu and COVID-19 vaccines for healthcare workers. Next slide, please. So one important component is that you need staff access to information. How can your staff get access to the information they need? How can they get access to the outbreak guidance documents from HPSC? Is there a copy of the line listing that they may work on during the night? There is one that will be provided by public health when you identify that you have an outbreak. But there is components that are very similar on every outbreak line listing. So the residents' vaccination status, your staff vaccination status, when your outbreak starts, and the symptoms. So they do need this information, and it would be useful for staff to have an idea of what sort of request is going to come on the line listing. Do all staff have easy access to relevant websites and the most up-to-date HSE AMRIC guidance documents, posters, and relevant websites? Winter preparedness in nursing home. and the contents apply to all types of residential care facilities, and there is a link there. Now, IPC measures will be discussed in further detail by my colleague, Professor Claire Rock, in her presentation. So the key contacts you need to have on an A4 sheet or available to all staff are your facility senior managers or the person in charge, medical officer and GP out of hours GP service or the EDIT service, your HICWA or mental health commission as appropriate, the Department of Public Health, your infection prevention and control service, your community support team contact details or the COVID response team, whichever is in running in your particular area, your vaccination team contacts, your laboratory contacts, your relevant manager or service responsible for maintenance, waste and laundry, pharmacy supplies, PPE ordering, and agency or staff contacts. Now, these contact numbers you need to have at hand. You can't, in the event of an outbreak or in the event of symptomatic residents, especially during the night, you need to have all staff having access to information so that they can contact the relevant people. Next slide, please. So the important things you need to educate. You need to reinforce the education of your staff in your 5 moments of hand hygiene, respiratory hygiene, and the appropriate use of PPE, including gloves, gowns, face masks. Staff are up to date with all appropriate training on their AMRI code and HSE land. It's important to order respiratory swabs, your COVID-2 there, swabs for PCR testing for COVID-19, influenza and RSV. Ensure your nursing home has a stock of 6 to 8 on-site in advance. Make sure your staff are educated to take the swab correctly. There is YouTube video there and arrangements for transporting the specimen to the lab. All your staff need to be aware of that. COVID-19 antigen testing is no longer recommended. Next slide, please. So here are some of the posters that are available, and they are available from both HPSC, but also the HSE AMRI team have printed a number of patient information resources, posters and guidance on material, and they are available through Health Promotion. So there's the standard precautions poster, your point of care risk assessment poster, PPE posters, hand hygiene posters, and your respiratory hygiene posters. Next slide, please. So the important thing with case identification and management is to ensure staff know how to recognise the signs and symptoms of respiratory illnesses. Advise to check hbsc.ie regularly for the most up-to-date guidance. It's important to realise knowing your residents is a very key component. You are with these residents for so many hours every day, you've built relationships with them, and you're very aware, and your staff are very aware of when they are on form or when they are coming down with any illness or infection. So you are the best and most suitable person to recognise any deterioration in their condition. Isolate a resident without waiting for confirmation of test results to reduce the further transmission within the facility. So ideally, we'd like every resident in a single ensuite room, but in advance, you may have an isolation plan for your residents, especially dementia patients or residents with behavioural challenges and multi-bay residents. This is part of your planning. So you need to seek clinical assessment and start immediate management following the point of care risk assessment for IPC and appropriate PPE as per the PCRA, droplet or airborne and contact. Apply transmission-based precautions to all symptomatic residents to help limit the spread of infection. Increase the frequency of environmental cleaning with enhanced cleaning and disinfection and terminal cleaning at the end of the outbreak. Ensure adequate ventilation with a gentle airflow whilst ensuring patient and resident comfort. Regular monitoring of the resident is required concerning the symptoms and clinical improvement. or in the case of deterioration, escalate for medical review as per local arrangements. Ensure your communication plans with families, staff and residents are kept updated, and an after-action review post-closure confirmation from public health, team brief which will support your staff, identifying what worked well for the team during the outbreak, what lessons were learned and what could be changed. And lastly, update your preparedness plan to incorporate these learnings. Next slide, please. I think there was one more slide there, but I'll now pass you back to Augustine. Thank you.
Thank you very much, Fionnuala. I was trying to find the unmute button. That's really helpful, Fionnuala. And our next speaker is Professor Claire Rock. Professor Rock is the consultant in infectious diseases and also the deputy clinical lead for antimicrobial resistance and infection control team, we all know as AMRIC team. The control of healthcare associated infections and antimicrobial resistance is integral to all healthcare workers who have an important role in providing safe and effective care. And the fundamental principles of infection prevention and control in health and care settings helps us to provide that safe and effective care. So let's hear from Professor Rock about some of that fundamental principles we have to keep in mind. Over to you, Professor Rock.
Thanks so much, Augustine. And yes, we're into another winter respiratory virus season. So if we move on to the next slide, Marie, two little announcements to make at the beginning. The first is that we've just updated our acute hospital infection and prevention control guidance, and also for the residential care facilities. So those updated guidances should go live on the HPSC website today, tomorrow, but very imminent. There's really the science hasn't changed, so there's no really substantive changes. There's some updating of links, and then there's some clarifications around occupational health and some additional links and information there. The second thing is to wish everybody a happy International Infection Prevention Week. It is the International Infection Prevention Week, and this really, and you may be seeing that around your health and care settings, but this really shines a light on infection prevention, and we really see it as an opportunity to educate and raise awareness. And really, infection prevention and antimicrobial stewardship really is everybody's business. And it's really trying to keep patients safe from infections. Many of you will know that the HSE hand hygiene training is mandatory for all HSE staff and staff in HSE funded services. And this really is because hand hygiene is such a basic principle of infection prevention and control, and really integral in maintaining safety for everybody, for health and care workers and for our patients and residents. If we go to the next slide, Marie, we can see some of the IPC measures we have, and we're all familiar with the tools to protect ourselves from others. And, you know, we've all been through the COVID pandemic, so we know how to do this and how this is done. There are a multitude of resources, as many of the other presenters have already alluded to, but one that we see as a cornerstone of many of the guidances that come subsequently is our infection prevention and control NCG, or National Clinical Guidelines. And you'll see the link here and some of the images of what that document looks like. And the purpose of these really is to support the care that meets the needs of the person. They're not a rigid set of rules, and they really need to be applied with care and compassion and interpreted, but they do offer some guidance and steering. And it allows for clinical and institutional decision making. If we go to the next slide, Marie, we can look at some more key infection prevention and control points. And I alluded to this a little bit earlier, talking about hand hygiene, but this is really the importance of standard precautions. And what do we mean by standard precautions? This means the approach that we take for interacting with every patient at every care interaction that we have. And this is good hand hygiene, recognizing the indications for hand hygiene, recognizing how to properly use alcohol-based hand rub and soap and water when appropriate. It's promoting cough and respiratory etiquette, so into tissues and disposing of those, and then practicing hand hygiene, or if unavailable, coughing into elbows. But really the idea is to try and limit the viral particles that are disseminating out when people have cough or other respiratory issues. Then consideration of patient and resident placement, and really trying wherever possible to have a minimum distancing of a metre between individuals in multi-occupancy rooms. And this is obviously to contain any viral particles that may be from a patient or resident who doesn't have yet have any symptoms. Enabling natural ventilation to the greatest extent possible. And then the next is really using a point of care risk assessment to support selection of PPE when needed. And you can see an image of this point of care risk assessment here, but this is really the cornerstone to apply to every patient to really understand what is the personal protective equipment that's needed to be used during that patient care interaction. Staff, visitors, and other service providers with any signs or symptoms of respiratory infections should stay away until symptoms have resolved. Surgical masks should be part of standard precautions if there's any risk of spray or splashes from a patient during that interaction. And then, as mentioned by all the speakers, really the importance of being up to date with vaccines. And this is staff, residents, and encouraging also our visitors that are entering into our healthcare facilities. If we go to the next slide, again, some more points, and this is transmission-based precautions. So this is when you have a patient that's known or suspected to have a respiratory virus. So wearing surgical masks when caring for patients who are known or suspected to have respiratory viral infections. If there's any aerosol generating procedures for that patient, then wearing an FFP2 or 3. And these masks should be fit tested and fit checked regularly to make sure that you're maintaining an adequate seal on that mask so that there's not air that's inadvertently creeping in around the sides of the masks. In general, the duration of transmission-based precautions is 5 days. If we go on to the next slide, we have some more specific information regarding this. But the period of isolation and transmission-based precautions for COVID and other respiratory viral infections such as flu or RSV is a minimum of 5 days from the onset of symptoms or the date of positive results, whichever occurs first. If the resident has no or minimal residual symptoms for 2 days, transmission-based precautions can be discontinued, but again, not less than 5 days from the date of symptom onset. And there may well be cases where extension beyond 5 days is appropriate based on experience and assessment of local risks, and also the specific patient, if they're immunocompromised or have any other reasons that they may be expelling virus for longer periods of time. For patients who receive antiviral therapy for treatment of influenza, the period of transmission-based precautions for them may be lessened, but for not less than 72 hours after antiviral treatment has begun. If we go to the next slide, Marie, we can see there's a significant number of e-learning resources that are available on the AMRIC e-learning hub. And these really cross a myriad of various different infection prevention and control and antimicrobial stewardship guidances and tools to help support staff. So I would encourage you to look at these. They can be really, really helpful and very informative. If we go to the next slide, Marie, this is a list of all of those e-learning resources. I'm not going to go through all of these. But many of you will be familiar with the hand hygiene one, which is the one that we already said is mandatory. There's introduction to infection prevention and control, and antimicrobial resistance and multi-drug resistant organisms, and antimicrobial stewardship. And then some of the basics of infection prevention and the different types of standard and transmission-based precautions that we've just discussed. So lots of very, very useful information here. So I'd encourage you to look at this AMRIC e-learning resources. This is more information, and these are hot off the press. They'll be distributed shortly, available for you in your facilities. But these are new transmission-based precaution posters to really support people out on the front line about how to don or put on personal equipment, protective equipment, and how to take it off. And then indications where gloves are not needed, so that we're reusing gloves in the appropriate scenario. So these, I think, will be very useful for people out on the front line. We go to the next slide, Marie, and you can see a huge focus of the work that we do is also around our patients. And so there's many different patient information leaflets that are available. And one just to highlight as a universal one is the one here being infection aware, and also one around antibiotic use. And so these are really all the principles of infection prevention and control and the principles of correct antibiotic use. And so those can be very useful for patients as general education tools. We go to the next slide, Marie. We can see we would be remiss if we didn't give some antimicrobial stewardship key messages. So many respiratory tract infections are viral or self-limiting and don't require antibiotic treatment. And most cases of otitis media or ear infection, sore throat, sinusitis, bronchitis are self-limiting and do not routinely need antibiotics. And this is very well known to the prescribers that are using antibiotic prescribing.ie. If an antibiotic is required, a 5-day course is all that is needed. And that's what's recommended if an antibiotic is needed. And really, there's very, very little indication for ever going beyond 5 days. If an antibiotic is needed for suspicion of bacterial tonsillitis, pharyngitis, or infective exacerbation of COPD, the duration is 5 days. I think we have one last antimicrobial stewardship message. For patients in acute hospital, oral antimicrobial therapy should be prioritized over IV whenever possible. And this has multiple benefits to the patients, reduces the risks of bloodstream infections and catheter-related infections by line removal wherever possible, but even accessing the line as less often as possible reduces the risk of bloodstream infection, which we know causes significant morbidity and mortality in the inpatient setting. For patients in residents in residential care facilities, RTI guidelines specifically on antibiotic prescribing.ie, there was a ceftriaxone position statement issued earlier in the year. Ceftriaxone is not recommended in empiric guidelines for treatment of infections in community settings. So just highlighting that as a piece of work that was issued earlier on in the year. It doesn't form routine antimicrobial prescribing in long-term care facilities. I think if we go to the next slide, Marie, that might be the key IPC and AMS points, and I'll hand back to Augustine. Thank you so much.
Thank you so much, Professor Ropp, for that presentation, highlighting some of the key fundamental principles for infection prevention and control and antimicrobial stewardship as well. So our next speaker is Dr. Ellen Hayes. Dr. Hayes is the ICGP representative. She's the HSC ICGP lead for adult sepsis, the clinical lead for adult sepsis. ICGP, or the Irish College of GPs, is the professional body for general practice in Ireland with over 5,100 GP members. Dr. Hayes will now talk to us about recognizing and treating acute respiratory infections. Over to you, Dr. Hayes.
Thanks, Augustine. Thanks for that introduction, and thank you to everybody for joining the webinar today. So as has been alluded to in the webinar so far, the control of the spread of respiratory viruses requires a comprehensive approach, and thanks to everyone who's spoken about vaccination and infection control already today. And today I'm going to speak about testing and treatment, which is a vital part of this approach. Before I go any further, I want to just specifically mention vaccination because it really is just so important. And I especially want to mention the needle-free pediatric flu vaccine. So as Professor Marin mentioned, this is available to all children between the ages of 2 and 17 in Ireland. And it's a really important vaccine for 2 reasons. Number one, it provides direct protection to our children. The vaccine is much more effective in children than it is in adults, especially in younger, healthier children. And also in that it provides indirect protection to the more vulnerable people in our society. When it can very inadvertently spread to people in our community, especially vulnerable people. So the more people that we can vaccinate, especially children, it can reduce the spread to more vulnerable people in our communities. As Professor Marin also alluded to, about 90% of all deaths from influenza occur in the elderly. And so I would really encourage people to promote the flu vaccine in children at any given opportunity. Now on to, I suppose, the real reason why I'm here today, and that's about testing and treatment for respiratory viruses. So first of all, to draw your attention to this algorithm, and I don't expect anyone to be able to read that algorithm as is on the slide, but it's available on the looking at. And today I'll be talking through some various points in that algorithm. So Marie, could you move on to the next slide, please? So just to speak about the definition of an acute respiratory infection, and that's the part of the algorithm that's highlighted in yellow there on the slide. So the definition of an acute respiratory infection is sudden onset of symptoms and at least one of the 4 following symptoms: cough, coryza, shortness of breath, or sore throat, and a clinician's judgment that the symptoms a resident has is secondary to an infection. Now, any of us that are working or have worked in a residential care facility know that actually it's just not that easy, and that we really need to consider soft signs for infection and deterioration as well. And these include things like decreased mobility, decreased oral intake, decreased appetite, increased agitation even, or increased withdrawal. So it's really important to use our clinical judgment here and to maintain a high index of suspicion for respiratory infection and illness during the winter season. Next slide, please, Marie. So if we think that a patient or a resident has an acute respiratory infection, a clinical assessment is vital. And there's, first of all, if our resident is being referred to a GP for an assessment, it's really, really useful for a GP to know if there is influenza or COVID in the residential care facility. It really would help us in our decision making and would really as well facilitate the earlier prescribing of things like Tamiflu within the residential care facility. I also want to mention that vital signs are vital. And these are really important, and I'm going to take the time just to spell out what the 6 vital signs are. So that would be heart rate, blood pressure, respiratory rate, oxygen saturations, temperature, and mental state. So in any resident that a deterioration is suspected or a respiratory infection, it would be really, really useful for a full set of vital signs to be documented and communicated. So vital signs provide an objective measurement of a patient's physiology, and they can really help as an adjunct to clinical decision making. It's really important that we see and document the vital signs, especially in handovers to a GP, if we're escalating care to secondary care, or even amongst nursing staff within a residential care facility. A full set of vital signs provides the base deterioration can improve outcomes for patients. So after clinical assessment, the next important question we need answered is, does the patient require hospitalization? So if it's decided that hospitalization is necessary in the event of suspected or sepsis, the patient must be referred urgently to secondary care. In any decisions around escalation of care, it's important to take into account patient wishes and care plans that may be in place with regard to escalation to secondary care. So next slide there, Marie. So if hospitalization is not required, but a respiratory infection is suspected, it is important to undertake multiplex testing. If multiplex testing is not available, then simultaneous separate COVID-19 and influenza swabs should be taken and sent. In the case of an outbreak, which is defined as 2 or more cases, it is important that the residential care facility reports this to the Director of Public Health in the area. At this stage, Public Health can advise, and really things are taken on a case-by-case basis, but generally speaking, testing of 5 symptomatic residents is generally recommended. Next slide, please. So this is a really important slide. So if influenza is suspected, it's essential that antiviral treatment is started early and on clinical grounds. So flu is suspected, start treatment early and on clinical grounds. Duration of symptoms. Number 2, it can reduce the period of viral shedding, potentially limiting transmission. And number 3, it is associated with lower mortality. So again, if influenza is suspected, treat early and on clinical grounds. There isn't any need to wait for a swab result to come back. Next slide, please. So if swabs have been sent and they come back, it's just a token. Be considered selected seriously immunocompromised COVID-19 patients. Now, practically speaking, if a resident has COVID-19 and is seriously immunocompromised, the likelihood is that this patient will be transferred to secondary care where Paxlovid can be initiated if deemed necessary. Practically, it's not usually initiated within the residential care facility setting at the moment. If a swab for influenza is positive, well, one would hope that Tamiflu or oseltamivir has already been initiated. But if it hasn't, consideration to initiation of it should be given. And ideally, Tamiflu should be initiated within 48 hours of symptom onset. And the antibioticprescribing.ie website is really useful. It outlines the treatment, the doses, and also gives some information about antiviral chemoprophylaxis. And the dose of Tamiflu is usually 75 milligrams twice a day for 5 days, but that can change if a patient is less than 40 kgs. Just next slide, please, there.
Sorry, Ellen, your sound is breaking up quite a bit. I mean, we were able to follow, but no, it's breaking up quite a bit. I should have come in earlier. Perhaps you can turn your camera off and try. Thank you.
Sure, yeah. So apologies for that. Can you hear me now?
Yes, we can. Yeah.
Yeah. So this is the last slide, and it's the primary care algorithm for patients presenting with respiratory tract infection symptoms to primary care. And again, that's available on the HPSC website, and the link to that algorithm is just below. So the most important part of this algorithm, this particular question, is the patient at high risk of severe or complicated COVID-19 or influenza? And depending on the answer to this, the algorithm goes in different directions. So if the patient is not at high risk of severe infection, well, then we should manage as per clinical judgment. Testing is generally not recommended. And as Claire already alluded to as well, antibiotics are generally not recommended as most respiratory illnesses are viral. If antibiotics are deemed necessary after clinical assessment by a clinician, then it's important just to refer to the antibiotic prescribing website for information about the agents used, the dose and the duration. So if the patient is deemed at high risk of severe infection, and these would be patients with chronic illnesses such as chronic heart, liver, lung and kidney disease, patients with diabetes, patients that have a moderate to severe neurological condition, patients who have learning disabilities, patients with Down syndrome, and these are just to mention a few. With patients like this, we should consider testing. And I suppose the most important point here as well is that high-risk patients in primary care that have suspected influenza, again, should be treated early for influenza and on clinical grounds. So just on to some key messages then, just to finish my presentation. Next slide, please. So the key messages I would like everybody to take from my presentation will be that vital signs are vital. Consider soft signs of deterioration. Please let the GP know if there is influenza in the residential care facility. Test early and treat early for influenza on clinical grounds. And in primary care, consider risk factors. High-risk patients may require testing and treatment. So many thanks for listening, and I'll hand back to you now, Augustine.
Thank you very much, Dr. Hayes. So our next speaker is Dr. Anne Sheehan. Dr. Sheehan is the Regional Director of Public Health in HSE Southwest. Slanted care reforms brought about 6 new regions. And one of the first executive directors that were appointed to regions was, in fact, regional directors of public health, thanks to the public health reforms that preceded some of this change within regions. So Dr. Sheehan reports to the regional executive officer and is a member of the regional executive team. We are very delighted to have you here, and Dr. Sheehan will now talk to us about clinical management of outbreaks. Over to you.
Thank you very much, Augustine, and hi everybody, and it's great to see these numbers on. There's a phenomenal amount of information being shared today, I think, and it's a lot of good food for thought, and I think probably these slides will be very valuable to people to go back and review for their preparedness. And I think we've heard a lot about vaccination, about the importance of testing, about the importance of infection prevention control practices. I suppose I'm just talking from the point of view of a regional department of public health, and we are your friend, and we are your sort of your go-to person if you have any queries, any questions. So I suppose what I would say first is the most important thing is everybody should be prepared. And we already heard a lot about the winter preparedness and the preparedness plan and what you need to do in order to gear yourself up in terms of, do you know how you will manage an RE if one happens in your facility? Do you know where you'll isolate, who you'll isolate, and how you'll do it? Having close linkages with your GP, or if there are a number of GPs, knowing when and how and where to get your test done. And then the other bit is a whole bit around vaccination. And I think it's hugely important that you will encourage that all your residents are vaccinated, and that it is documented in their notes, in particular whether they've had COVID or flu or both. And also to encourage the staff. The vaccination teams are going in at the moment, and that's an opportunity for staff to avail of it there, but they can also attend their GP or pharmacy, as Louis said earlier. And then I think it's also important to know whether their other vaccinations are up to date. So next slide, please, Marie. So again, I'm talking about outbreaks. So I suppose this is what to do when you suspect that there's an outbreak. And again, it's 2 or more suspect cases where they're linked either with similar type symptoms in the same room or ward, or during the same period of time. And the first thing is to make sure that they're isolated. And as Professor Rock said, in putting the appropriate infection prevention control precautions in place, and then testing and considering the number of tests you will do. So you've done all this, and you've got your test done, and then it's confirmed that you do have an outbreak. So your next step is to contact us in the Department of Public Health and let us know, because well, there's legislation that says you have to tell us anyhow under MOH legislation, but we're also there to sort of support you through that outbreak and to help take the next steps. Next slide, Marie, please. So what we will want to know when you contact us initially, we want some general information in terms of the layout of the building. Is it a single-story building, multi-story? Are there multi-occupancy rooms? Have you en suites? Have you shared bathrooms? Because this is all very important to actually get a picture of the outbreak and how it might spread. Your number of residents on site and where they're located in terms of floors or whatnot. Your staffing numbers and the staffing practices in terms of their changing areas, who covers what, where they eat, the different disciplines, and then also whether you've got any other services coming in from outside, to know what those type of services are and how often they come in. Again, as I mentioned, the vaccination status, and to ensure that the staff have all their training in place, and that you've got appropriate PPE on site to manage the outbreak. Next slide, please, Marie. And again, then we want more specific information in relation to the actual outbreak itself. So our first thing would be to know about the cases. When did you identify your first case? When did they become symptomatic? Again, looking at the incubation period, about that which is important as to who might be exposed during that period. When they were isolated, have they been seen by their GP? Are they currently on treatment? What treatment are they on? And what's their status? Are they improving? Are they disimproving? Have they been hospitalised? And it's very important for us to know how many people have been hospitalised, because as we all know, our hospitals are under ferocious pressure at the minute. And it's probably going to get even more critical as the winter season goes on. So it's important, and we do link with our local hospitals and let them know where there are outbreaks, because it's important for them to know when patients are being admitted from residential care facilities. So we will also want to know the number of lab confirmed cases and the severity of those cases. We'll also, particularly for flu, we'll want to know that an update on the contacts and how they're being managed and their vaccination status. We'll be looking for information on your isolation or cohorting plan, and your staff management. So I suppose just because the control measures are hugely important in terms of trying to get the outbreak under control. So I suppose the first critical thing is the vaccination to protect them. Secondly, and I think as was said just now about the importance of testing early, treating early, because that's hugely important, and discussing it with, we will often discuss it with the GP or get used to discussing with the GP in terms of just saying that there is flu in the facility. Have you considered Tamiflu for flu cases? And it's hugely important for the case and context. It does prevent spread of flu. And again, I suppose I've already said the other thing we will be looking for, because we need to keep a track of the outbreak. So we'll be looking for a line list in terms of, and it's very good for you as well in the facility, in terms of the number of confirmed cases, the number of suspect cases, and the number of them both in both of the staff and in the residents. Next slide, please, Mary. Again, we'll be looking for your staffing plans. I mean, we'll be advising you around a lot of these things in terms of your staffing plans, supporting your around the IPC measures, advising around environmental cleaning and enhanced cleaning, determining cleaning as patients come out of isolation, advising around what activities should continue, what you should consider pausing. Again, about that is hugely important about informing visitors. And about advising them, we don't want to stop visitors coming into any residential care facility or into any facility, but it's important if in terms of both visitors bringing in infection, but also them, if they're vulnerable, becoming cases themselves. So they need to be informed and advised. And the other bit is around admission and discharge of patients. So we don't say that you can't admit to a facility during an outbreak because again, and a lot of this is a lot of hospitals are under severe pressure, and patients that have been admitted may need to come back. If patients can be admitted into the facility safely, then that should happen. But it's important that it's done safely, so that does need very careful management. And again, I think communication is key around all of this with your residents, that they know what's going on, with the staff, with visitors, with the local hospital, with your GP, and with services that are coming in and out. And finally, just all outbreaks do eventually come to an end, but it's important that once they come to an end, that you agree that when the outbreak is over, you may be admitting patients before the outbreak is actually declared over, because it's two incubation periods from the isolation of your last case. I think it's very important to actually do your own report and to include in that lessons learned. What would you do better next time? Would you have done things faster? Would you have informed, gotten onto the Department of Public Health quicker in order to get advice? And again, sharing the learning with staff is important, because they need to know and they need to become empowered to actually make decisions themselves and to know how to actually manage and to report early. I know you've been bombarded with information at the moment, so I'll finish up now and hand back to August, and thank you very much.
Thank you very much, Dr. Sheehan, and I know you have to leave fairly quickly, so we might jump straight to the Q&A. I'll come back to the supporting resources after that, if that's okay, because there's one question that if you're able to stay on, it might be helpful to just tease out those questions on the chat about outbreak. When is an outbreak declared, and what's the definition of an outbreak? But also, if your point about residential care facilities doing their own report is a point really well made about lessons learned from how the residential care facility, or a healthcare facility for that matter, a hospital or any setting, manages an outbreak is really, really vital, isn't it? So any thoughts on that, Dr. Sheehan or anyone else of the panel? I know Dr. Sheehan had to leave and had something urgent to go to, so maybe she's gone. Anyone else would like to comment?
I think, Augustine, just the importance of infection prevention and control in addition to vaccination. So just making sure that we're recognizing any patients or residents that may have symptoms, and especially in an outbreak situation, that we really have that level of suspicion for patients who develop, cough, fever, shortness of breath, sore throat, any of the symptoms. But really in the setting of a context and in the context of an outbreak, you're really thinking until proven otherwise that that's symptomatic of whatever respiratory virus you're trying to deal with. So the importance of the basic and then transmission-based infection prevention and control, I think, is critical there. And then the pieces related to vaccination, which can be done in advance, right, to try and prevent or at least prevent serious infections. So really ensuring that as many as possible. And we've been on site visits around the country and seen, you know, various healthcare settings with, you know, prizes and things related to really having their health and care workers vaccinated. So really would encourage those kind of incentives and recognitions for those areas that do have high levels of vaccination. And then also obviously vaccination of our patients and residents is critical also.
Thanks very much, Claire. And another thought that comes to mind is about vaccination during an outbreak. And I'm wondering whether, Sabrina, you might be able to advise what might be the steps that the teams, mobile vaccination teams, have been putting in place to try and facilitate nursing homes or healthcare facilities that might have cases whilst you are going in to immunize and vaccinate people.
Thanks, Augustine. I think our key advice there is always that important relationship of linking with the public health department. Our vaccination teams would take guidance from the public health department as well. Considering the facility and all the things that Anne covered there, you might be able to segregate some patients and proceed with vaccination, but really it would be on the advice of the local public health department that would advise our vaccination teams.
Brilliant. So that link in...
Sorry,
I
was just going to add that it's very important to say as well that the mobile vaccination teams, if it is advised that they don't attend that facility on their scheduled visit because of an outbreak and public health make that decision, they will come back. They will schedule them back in as soon as they possibly can. So there won't be any missed opportunity for vaccination.
Thank you, Sabrina. That's really reassuring as well to know that, and that important link with the Department of Public Health for jointly undertaking that public health risk assessment is key here, isn't it? So look, I might just go through some slides about supporting resources and then we loop back into Q&A. So whilst I'm going through supporting resources, could you think of further questions that you might have had whilst listening to the presenters, or anything else that you had previously that you felt was unanswered? We can take them up if you post them on using the Q&A function on the Teams channel. So this next few slides will be, well, all the slides will be available on the website. The next few slides pulls together some resources and points, links that are very useful for teams in terms of preparing and responding to winter pressures. So this is the lab pathways for all across the country, essentially. So NVRL is used by Northwest, Mayo, Northeast, and Dublin as the testing lab. They're also used as the reference lab, of course, for those areas. And in West, Midwest, Southeast, Southwest, and Midlands, they use the local labs as their testing labs, and they, of course, use NVRL as their reference lab as well. But important point is, please do check with your lab to confirm the arrangements for testing. This was identified following a survey that we undertook 2 years ago, but the lab pathways have not changed from our knowledge, but you might have more local knowledge from your regional working within your regions itself. Next slide, please. So this is where the AMRIC training modules are located on the HSE land. Sometimes it might be not so straightforward to find it on HSE land. So once you log on to HSE land, select the hubs and resources on the top right-hand corner highlighted in green in the image there. And once you go on to hubs and resources, if you scroll down a little bit, you'll see the AMRIC hub and all the resources from AMRIC, and there's a wealth of resources there on HSE land for AMRIC training, for IPC training that AMRIC have pulled together. They're all available on the AMRIC hub. Next slide, please. This table just presents some of the additional guidance that's available, produced by AMRIC and led out by AMRIC. Next slide. This table presents some of the resources available on the HPSC's website, and it includes the Public Health and Infection Prevention Control guidance on prevention and management of outbreaks and cases in residential care facilities. This is led by AMRIC. It's hosted on the HPSC website. There's various other resources that are available. And I'd like to also highlight the acute respiratory infection guidance page, which is on the new acute respiratory infection page. We also have a winter preparedness page, which is coming on in a future slide. Next slide, please. These are resources pulled together by the community support teams, and they're available, which includes the final report from the COVID-19 nursing homes expert panel, which is once again a very useful read. And there's also the national standards for IPC and community services document and various other resources as well. Next slide, please. These resources have been pulled together by our colleagues in NIO and brings together information for healthcare professionals on vaccinations. There's leaflets, there's guidance, there's also links to websites for flu, COVID, and healthcare workers specifically as well. There's also an email for healthcare professionals to send in clinical queries in that page as well. Next slide, please. And these are the e-learning resources on HSE land that NIO have produced, which includes talking about immunizations. In addition, on the slide, there's also additional resources from the WHO and ECDC. Next slide. This slide presents some of the vaccine training modules that NIO have produced. Once again, if you log on to HSE land, go on to catalogs this time. And under catalogs, if you select National Immunization Office, you'll see the resources that NIO have produced that support you as well. Next slide. As mentioned by Dr. Sheehan, the regional departments of public health will need to be notified of cases and outbreaks of acute respiratory infections, COVID, influenza, and RSV. And these are the contact details. If you click on the link on the top right-hand corner, it goes straight into the HSE webpage, which lists the contact details for each of the 6 public health regions. Next slide, please. And in terms of access to this webinar, the webinar recording will be uploaded onto the Winter Preparedness webpage on HPSC website. You can access it either using the A to Z index, or the QR code on the right side, or the link at the bottom of this page, and that takes you straight to the Winter Preparedness website. There's resources available there for residential care facilities, for childcare settings, but all advice for childcare settings, but also advice for congregate facilities there. Next slide. That brings us to the end of the slideshow, and we'll continue with the Q&A, and we'll take some of the questions on the Q&A chat. But I think there were a few points on the chat as well, which I'd like to highlight. And of note, I'd like to pick out one of the questions that emerged from several people. I think it's about antigen testing and a discrepancy between guidance and practice. So let me just bring up the question on the Q&A. The Q&A mentioned, if COVID antigen testing is not recommended anymore, how are staff going to test or rule out if they are symptomatic? So I'm just wondering if Professor Rock or Dr. Hayes would like to comment on this.
I think from a perspective of infection prevention and control, Augustine, the really important thing for healthcare workers is if they do have fever and any respiratory symptoms, that they are likely infectious, independent of what the virus is. So anybody with fever really should not be attending a workplace, and certainly not in a health and care setting. And really a lot of it is moving towards symptom-based recognition of acute respiratory infections. So I think from the perspective of infection prevention and control, if someone has fever, really they're likely to be infectious with whatever virus it is that they have, and ideally should be fever-free for 48 hours without taking any fever, paracetamol or any fever treating medications. And then I suppose there can be people that have a lot more minor respiratory symptoms, and those can be more difficult to understand, you know, the level of infection that they may have. But in general, if people are feeling ill, they should stay at home from work until they're feeling better.
Thank you, Dr. Rock. Dr. Hayes, would you like to add anything?
There was a question there as well, I think, about, you know, GPs testing for respiratory viruses. And if we look at their algorithm, it said consider testing for respiratory viruses. And just my own personal experience on the ground is that I suppose testing isn't done routinely for patients presenting with acute respiratory illness. A GP will make their own clinical decision based on the clinical information and examination findings in front of them as to what the next best course of action should be. If influenza is clinically suspected, we don't actually need a swab result to come back positive to initiate treatment. And also, I suppose one of the most important questions is, does this patient need escalation of care to secondary care? So that's one of the first things that will come into a GP's head is do we need to refer this patient? Are they sick enough? So yeah, testing, it says consider, but in my experience on the ground is not happening regularly.
Thanks very much, Dr. Hayes. And I agree. I think the point is about interventions, including isolation, infection prevention control measures, or requiring antivirals or treatments. They don't depend on whether we have a positive test or not. And often, you know, that's probably one of the important things to consider. And once again, the reasons why we're not using antigen test anymore is, I mean, when we had a high circulating level of disease, antigen tests might have served a purpose at that stage. We are in a very different situation. We're not in a pandemic situation. And the HSC EMT, or I think it's called the Senior Leadership Team, isn't it, discussed a paper that Professor Martin Cormick and AMRIC colleagues and National Health Protection took about the usefulness of antigen tests, and the rationale for not requiring antigen tests was that self-testing fails to detect SARS-CoV-2 in a high proportion of people and who have SARS-CoV, and that false reassurance that a negative test result is dangerous as well. So that's another reason why we do not rely on antigen tests, and we have moved away from the situation when we were in the height of the pandemic, when we were using antigen tests quite a lot, to using multiplex PCR testing. The other reason is quite often, especially when we see influenza rates increasing, it's influenza that is most likely to be causing concern in a nursing home or a healthcare facility, and an antigen test does not test for influenza. So we might be missing another significant cohort, and a negative test will give a false reassurance about no disease circulating, whereas in fact we might be having influenza or potentially RSV. Hence the importance of using a multiplex PCR test. We also heard from Dr. Hayes earlier about the need to test the first 5 cases of symptomatic residents in a nursing home. Once we know certain virus is circulating, the subsequent cases will most likely be the same virus. Of course, there's a place for risk assessment, clinical risk assessment, and if the situation deems further testing, that may happen based on GP or public health risk assessment as well. Hopefully that answers the questions about antigen tests and use of various testing modalities. Another question that came up was about initiating Paxlovid, and Dr. Hayes, you did mention more than likely it is initiated in secondary care, but it could potentially be also initiated in primary care if depending on clinical presentation. That's and I've seen some messages on the chat that some GPs have done that. Would you see that as practice as well?
I would say that was more commonplace during the pandemic than it is at the moment, and there are complexities around that involving, you know, patients' past medical history, their renal function, whether or not they have any underlying hepatic disease. So, for example, if we don't have a recent renal function on a patient, it's very difficult to initiate Paxlovid in primary care. So it's difficult, but not impossible, and must be taken on a case-by-case basis, I'd say, Augustine.
Yeah, thanks so much. I agree that it's on a case-by-case basis, and it's a very select group, isn't it? Treatment may be considered for selected seriously immunocompromised COVID-19 patients, and quite often they might progress to severe disease fairly quickly, and they might, I mean, as you mentioned on the call earlier, might be admitted into a hospital quite early on as well. And as you mentioned, on a case-by-case basis, these decisions can be made. So I'm just looking through the Q&A. HICWA recently asked an RCF to maintain staff influenza vaccination records in their report. Could you clarify whether this is a requirement? Thank you. We may or may not know this, but we may be able to come back to you. But I'm just wondering whether, Fionnuala, you have any information on this, or anyone on the panel has any information on HICWA requirements for maintaining staff influenza vaccination records?
Sorry, Augustine, no, I don't have any information. It's my understanding that as managers of residential care facilities, you couldn't ask the staff if they have been vaccinated or not. But the line listing would have a line on it that would say when they last had their vaccine. So I'm not clear on what HICWA's requirement is there.
Okay, thanks. And we might link in and find out from HICWA what's their position on staff influenza vaccination as well. Thank you. So if the NVRL, another question, and we might finish there unless there's any more on the chat. The last question on the Q&A is, if the NVRL is running out of swab supply, do we have any other resource? Would anyone be able to respond to this? And my gut instinct or initial feeling would be that you would know which lab you're sending your test sample to, and it's that lab that you would request swabs from. So make contact with your local laboratory. It's not always the case that NVRL is your local lab, as we saw on one of the previous slides. Some of the northern areas are served by NVRL as their testing lab, and much of the country is also served by the local hospital as their testing lab. So make contact with the local laboratory or your testing laboratory, who will then be able to advise what swabs to be used. So can staff obtain multiplex swab if antigen tests are not now recommended? I think you addressed that in your talk, isn't it, Fionnuala, about how they can obtain multiplex swabs?
Yeah, it's normally from obviously your lab that you're using, and most of them, I know I can specifically speak about NVRL. It is from their menu. You don't necessarily have to identify patients' details, but you can put in. But you won't get. You will look. The maximum you will get will probably be about 10 of those.
Yeah.
Unless you are in outbreak and you require more, or it's advised by public health.
Lovely. Thank you so much, Fionnuala. So look, that brings us to the end of this webinar. The webinar is being recorded, and I think several of you were asking where can we find this webinar or to share with other colleagues who were not able to make it today. The webinar recording will be uploaded onto the Winter Preparedness webpage on HPSC website. So if you Google search Winter Preparedness HPSC, that should come up on your search engine. So give us a few days and we'll be uploading the recording from today onto that page, and you can share it with your colleagues as well. Thank you so much for participating, and can I thank Marie, who's in the background and supporting us with this webinar, but also every single one of you who attended, and a special thanks to the speakers for sharing their knowledge and expertise today. Thank you very much. Have a good afternoon.